broadcast is now starting. All attendees are in listen-only mode.
Good evening, Leon van Rensburg, RSSI Congress Director. It's my pleasure to welcome you to another of our head and neck imaging webinars presented by Dr. Richard Wiggins from the Department of Radiology and Imaging Sciences, Otolaryngology, Head and Neck Surgery at Biomedical Informatics, University of Utah. You all are well aware of his excellent teaching and professional skills. And tonight, the topic of our lecture is Fallor Ergo Sum. So perhaps I should just quickly elaborate on this without revealing my age. When I was at school, Latin was our third language, and that actually is a philosophical proposition by the French philosopher René Descartes, who was a mathematician, scientist in the 16th century, but it means Fallor Ergo Sum means, if you translate it directly from Latin into English, I think, therefore I am, or alternatively, in the head and neck or in medicine, I err, therefore I am. So misadventures and head and neck and imaging happens, and that is the most, I wouldn't say humiliating, but very bad experience to have a surgeon coming back to you or oncologist to say that you missed it cold or you misinterpreted, and that just always brings you back to the basics. And it always takes a great man to acknowledge his or her, or great man or woman for that matter, to acknowledge his or their own mistakes. So without any further delay, over to you, Rick. Let me hear about your misadventures. Thank you.
Okay, thank you, sir. This is kind of a different talk and a different lecture than some of my other talks in this series. This lecture really grew out of our own QA or M&M conferences. When we digitized our system here at the University of Utah about 20 years ago, I tried to help with the computers at a lot of the QA or M&M conferences that we used to have. And I started to think, I saw a lot of different reasons why people described how they missed things or why they missed them, and tried to think about the own internal reasoning of why people said they missed cases. And this lecture kind of grew out of that, why we miss things and how we think about them. So I have nothing significantly to disclose. You can just assume that all these cases are mine. None of them are mine. But I'll be going through and talking about how our reasoning sometimes can lead us astray. So we're going to think about some imaging pearls and think about why we miss things and suggest some techniques to minimize future things in terms of our own logic and rationality. So as you said, Dr. Van Rensburg, Descartes first described cogito ergo sum, and in French it's something else. He was actually French, but the idea there is I think, therefore I am. I'm going to give you a different phrase that I think may be more helpful in our world. Instead of thinking about that, I try to think about Fallor Ergo Sum, roughly translated to I fail, therefore I am. The idea here is to think more about wrongness. And I think that error and the mistakes that we make are actually essential to our progress to advancing science. You know, we talk about it, we publish our successful science, but there's a lot of things that fail on the way there. And I want to give you the opportunity to become intimate with your own fallibility. We all make mistakes, but if we can learn from them, that's something that's important. And I think we can learn a lot more from our own errors than we can from our correct diagnoses. And it's always better when you can learn from somebody else's error. That's always a big thing. Now, there's a lot of different categories of errors when we think about an overall picture, and a lot of ways that things can go wrong, including design errors and operating errors, errors of planning, execution, how we set up things. There's a lot of different ways for us to make errors. And we've actually seen a lot of this in science over the years. When you think about things like the Earth is flat and bodily humors and cold fusion, phrenology, there's a lot of stuff in our world in academic medicine that we think about that has been proven wrong over time. But for some period of time, all of these things were thought to be true and proven by science. And when we think about that scientific method, we observe something that leads to a hypothesis, we experiment with that, and things that are reproducible that lead to a theory that we think about as logically consistent with an explanation for that phenomenon. Now, we don't see a lot of this actually in radiology. A lot of the radiology literature is case series and retrospective series. So we don't see a whole lot of this. So when we do have the opportunity to do it, we want to pay attention to that. Now, we have a lot of reasons for why we miss cases. So I kind of sat on the sidelines and ran the computers for other people when they were doing their own QA conferences and talking about this. And I saw a lot of people give a lot of reasons for why they miss cases. And it made me think about all the different ways that we can miss things and why we miss things. And this kind of grew into this lecture itself and the idea behind Fallor Ergo Sum, I fail, therefore I am. Now, interestingly, we have different ways of thinking when we look at cases. If anyone's familiar with Daniel Kahneman, he was actually a psychologist who, interestingly, won the Nobel Prize in economics for his article, his paper about thinking fast and thinking slow. Now, I think about this rather simplistically as thinking fast of things like biases. And we have fast thinking and slow thinking that we use all the time when we're interpreting our images. So we all have implicit and explicit biases when we think about cases and when we think about our imaging studies and how we interpret them. If you ever want to prove your own implicit and explicit biases to yourself, if you just take a deck of cards and think about separating out all the red cards and all the black cards, that is a lot faster than if I were to tell you, put all the clubs and the diamonds over here and put all the hearts and the other cards on the other side. Separating those in those different ways is very different to think about. So we have implicit and explicit biases, things we're aware of and things we're not. But we also have slow thinking, and that's where we have logic and rationality. And that is a lot more interesting to me, how logic and rationality sometimes leads us astray. Now, sometimes we look at a case, and this is fast thinking. If I see something around the skull base and the facial bones, and I see that it's expansile and it's ground glass, I recognize that immediately as fibrous dysplasia. That's an example of fast thinking. But we also have slow thinking, where we can think about when we use logic and rationality. And just as a teaser for our next lecture next month on the central skull base, we had this unknown case that we came in and we did a CT, and then we followed up an MRI, and we saw what it looked like before contrast, what this lesion looked like after contrast, what it looked like on the T2, and what it looked like on the sagittal imaging. So we had this unknown skull base lesion. This was an area where we really needed to use slow thinking, and we needed to think about logic and rationality and how we arrive at the right conclusion. And this case was a great example of slow thinking, and we'll review that case and talk about logic and rationality next month when we do our central skull base talk. So I'm going to talk about all these different ways that we miss things. So first we have mistakes and slips, and then we're going to look at and spend most of our time on deductive, inductive, and abductive reasoning. These are the things that are actually more interesting to me in terms of logic and rationality, and how sometimes we're led astray by what our own rules and what we've been taught and how we think about imaging in the head and neck world. So to start off with, we'll talk about mistakes and slips. So we have this cognitive sciences and human behavior and error rules that talk about skills, rules, and knowledge-based classifications. And we have the mistakes and slips that are included under this grouping. So mistakes are when we have incorrect intention, that we actually have a gap in our knowledge in terms of rules and knowledge domains. If you just don't know something, you don't know any better. That's an example of just a mistake on a case. If you've never seen something before, it's easy to see how you could miss that. So here's an example of a case. This patient was brought in and was called diffuse facial lymphoma. And they had asked the patient, have you ever had anything injected in your face? And we see these areas of abnormal subcutaneous soft tissue where we should just have fat, where we sometimes talk about the SMAS, the superficial muscular aponeurosis space, or superficial muscular aponeurosis system, where we should have subcutaneous fat. There was just all this abnormal soft tissue there. And we asked the patient, and they denied having any procedures done or anything else. But if you've seen this before, it looks a lot like different cheek injections. And after we asked this patient over and over again, we finally got them to admit that they had actually had cheek injections. They had gone down to South America and had injections in their cheeks for cosmetic purposes. But if you had never seen this, that would be something that would be very difficult to evaluate. Now, PET-CT is very helpful in some things. We talked about it a little bit earlier, but we know that where CT sometimes obstructs our area when we have a lot of streak artifact from dental amalgam, that's an area where the nuclear medicine study can be very helpful around all that dental amalgam to see things. But we want to be aware on CT of all the false positives and false negatives. This is another study that was read out as negative by our nuclear medicine physicians because there was no real increased uptake in this area. But this is an obvious pathologic lymph node on this CT. But because there was no increased uptake, it was called negative on this PET-CT study as read out by our nuclear medicine colleagues. So I consider that a pitfall of PET. So there are other mistakes sometimes where we're just not familiar with the anatomy and complex pathology and how it affects the head and neck. The head and neck world is very different than other body parts because we have all this very, very different anatomy in these different parts. The cranial nerves, the central skull base, the temporal bone, the upper digestive tract, the orbit. It's very complex anatomy, but very different between these different places. So this is an example of a case where if somebody just had not seen something before or wasn't familiar with this pathology, you can really be led astray. This is a complicated case that was called an enhancing tumor. And they said that the tumor invades the parapharyngeal fat. Well, that fat is actually way back here. So it doesn't actually look like that tumor invades the parapharyngeal fat. And the tumor was described as destroying bone. But when you look at the bone, it actually looks like it's mostly bowed, not destroyed. So that's a very important thing, especially around the central skull base when we talk about the words we use to describe osseous changes. Also, in this case, it was described that the tumor was eroding the pterygoid plates. And you can actually see both the medial and lateral pterygoid plates, and they're actually in the correct position here. They're not being destroyed. And the differential for this case was tumor, tumor, tumor. And if you actually look at this, this is bright, but the nose is actually dark here. The nose. This is actually before contrast. So this was actually bright before contrast. Another kind of mistake in this report was that the tumor was described as invading the inferior rectus. And you can actually see a fat plane between the rectus muscle in this lesion itself. So there were a lot of kind of descriptive words because this person initially brought up this study and they immediately thought it was a tumor. And this was actually just a spontaneous organizing hematoma. And it was actually bright. All of these images I showed you were actually before contrast. This is actually just blood products in the nasal vault. So a significant change in this patient's therapy and how they were worked up, thinking this might be a tumor versus this is just a hematoma. Here's another example of a case. If we look on this graphic, we see abnormal spongy bone being laid down, and there's this small area here that's right in front of the oval window that we think about sometimes with otospongiosis or otosclerosis, and that anatomic area is called the Fissula ante Fenestram, the small fissure in front of the window. Now, this is the densest bone in the body. It should be bright white all the way around the cochlea and the vestibule. And in this location, we've lost that bone density. This is the Fissula ante Fenestram. And this is an area that's commonly missed in patients who have some hearing loss with otosclerosis or otospongiosis. And it's one example of a case where if you had never seen this before, it would be very easy to miss that at this location. Now, here's another case that was thought initially to because it was bright on the T1 before contrast, it was thought of as fat, similar to this fat that we see in the petrous apex on the pre-contrasted T1. Here the nose is dark, so this is before contrast. When we give contrast, though, we see that there is some enhancement, even though there's some bright signal beforehand. And this was initially called out as a lipoma, and they were having a discussion between dermoids and epidermoids and teratomas and some kind of congenital pathology. If you had never seen this before, this could be confusing, but if we have a lesion centered on the back wall of the petrous apex near where the vestibular aqueduct and the vestibular duct and sac are, we know that that's something we see with endolymphatic sac tumors. So it turns out the duct is just a couple of millimeters behind the vestibule, but we sometimes see endolymphatic sac tumors arising as lesions along this back wall, and they sometimes have blood products within them, so they might be bright before we give contrast. But it's an example of a case where if you had never seen this, you could easily be led astray by those findings. And if we do have an endolymphatic sac tumor, it's characteristically centered in the posterior aspect of the petrous apex, posterior and lateral to the internal auditory canal, and it has that characteristic osseous change, and we see it centered just behind the vestibule, where we think about that endolymphatic duct and sac coming off the back. Here's another example where this patient on this MRI before contrast, there was thought that this patient had multiple abnormal lipomas within their cervical soft tissues. And again, this is something where if you didn't know about it, it would be easy to miss. This is actually a differentiated thyroid carcinoma case, and this is actually the primary tumor within the thyroid, and there was very bright signal intensity on T1 within these lymph nodes at that level, and this patient with a differentiated thyroid carcinoma. But if you hadn't seen that before, you would not think about this colloid material being very bright on T1 as one of those things that are bright before we give contrast. Now here's another case. This patient came in, and on cross-sectional imaging, we see a lesion centered at the jugular foramen with very permeative destructive changes to the surrounding bones. This case, though, went directly to a radiologist who only did interventional work. And they had an MR, and they showed this lesion centered at the jugular foramen that looked like it had a lot of flovoids. And because the radiologist who this study was shown to really was focused on vascular work, they really did not do any cross-sectional imaging, they interpreted this lesion at this location as a vascular lesion and likely a AV fistula or AVM of the bone. Now, if we have smooth scallop margins at this location at the jugular foramen, here's smooth scallop margins, we know that that's what we see with a schwannoma of the jugular foramen. And if we have a lesion that goes centrifugally and it has dural tails kind of going in all directions, that's what we often see with the meningioma of the jugular foramen. And if we have a lesion that looks like a marrow replacing process, so here we have bright coronal T1 signal on one side, on the other side we've replaced that bright fat. That's a marrow replacing process. That's a good appearance for a metastatic focus of the jugular foramen. But this case where we see this permeative destructive change to the bone centered at the jugular foramen, that's good for a paraganglioma. And we know that these are very vascular lesions, so they have a lot of flovoids at that area. This particular radiologist, though, who only did neurointerventional work, decided to do a catheter angiogram on this study, and they showed all these vascular loops, and they saw a connection, what they look like between the arteries and the veins. It looks like there's early dural venous draining here. So they thought this was a dural AV fistula or AVM, and they decided to go ahead and coil that lesion. So they decided to coil off the dural venous sinuses to try to stop this dural AV fistula or AVM, and they added more coils, and they put in even more coils, and then they went around from the other side and added more coils from that other location. That, as you can imagine, the post-therapy imaging, the lesion is still there. We just have all these coils now in the transverse dural sinuses. So we didn't change this patient's follow-up or outcome in this case. And when they repeated the angiogram, it looked like the dural AV fistula or AVM had just recurred. All those collaterals came back in the same area. Now, if we look at this imaging and the postoperative MRI, they ended up going in to do surgery on this paraganglioma, but all those coils that were in the dural venous sinuses just made the surgery more difficult and more complicated. So this was a case that was very misleading because the radiologist just didn't know better about that cross-sectional anatomy. The lesion itself was still there, and after all those angiogram coils that were placed intravascularly. Now, if we have permeative destructive change, we know that that's a great appearance for a jugular paraganglioma. If we have sclerotic margins with increased density, that's great for a meningioma. And if we have smooth scallop margins, that's what we classically see with a schwannoma. This is an area where if we paid attention to those osseous changes on cross-sectional imaging, we should have been able to tell exactly what this pathology was. But if you're not familiar with this description and these osseous changes that can be seen around the jugular foramen, we're never going to guess these pathologies based on how they affect the bone. Because if these same pathologies are in a different location, we may get very different osseous changes. But if they're centered at the jugular foramen, we get very classic characteristic changes, which help us make the diagnosis. So a slip is different than a mistake. With a slip, this is something that you did know better, you just made a mistake. It's like saying right instead of saying left. But this is an area where we're misapplying our knowledge, our competence. And one example of this is satisfaction of search. Sometimes we're looking at a case and we find a finding and we stop looking for anything else. That's the idea behind satisfaction of search in these cases. So here's an example of the case. This is a subtle case that had perineural tumor spread. And this is actually the primary tumor that was on the patient's skin. And there's actually perineural tumor spread that was going on the infraorbital nerve below the orbit back in the retromaxillary fat pad. So this is perineural tumor spread back here. But if you're not familiar with perineural tumor spread, this is very difficult to evaluate. And people who don't do this routinely may have a lot of trouble evaluating perineural tumor spread in these cases if you're not familiar with that finding. And perineural tumor spread is really kind of the head and neck imager's shtick. Outside of the head and neck world, we don't talk a lot about perineural tumor spread itself. Now here's another case. If we have a patient, especially if they have hearing loss, and we have a lesion that is centered here in the internal auditory canal, as we see in this case, we're going to be thinking about a vestibular schwannoma if we have a lesion like this. It's in the internal auditory canal, it's in the cerebellopontine angle. Now, the problem here is that while we're usually thinking about vestibular schwannomas, a nerve sheath tumor that's arising from the vestibular or the superior or inferior nerves, the vestibular nerves that are in the back, we want to look very closely to see if there's any enhancement along the labyrinthine segment or in the geniculate ganglion to tell us that this is actually a facial nerve schwannoma rather than a vestibular schwannoma. The problem here is that even though these are rare, about half of the patients who have a facial nerve schwannoma, the internal auditory canal, they may present with hearing loss because some cranial nerves are more sensitive to external compression than others are to internal derangement. And this is a great example of that. This is a case where we had a facial nerve schwannoma, but the patient presented clinically with hearing loss. So that's very deceiving when we're thinking about a facial nerve schwannoma. So anytime we have a lesion of the internal auditory canal, we want to look very closely at the labyrinthine segment to see if there's any enhancement along that course to tell us that this is actually a facial nerve schwannoma rather than a vestibular schwannoma, a very important differential. Now, another thing that we want to think about is lymph nodes. If we don't look for lymph nodes, we're not going to find them. This is a patient who had chemoradiation, and he had a hypopharyngeal squamous cell carcinoma, and he was having a sore throat a couple of years after his radiation. And this was a positive pathologic retropharyngeal node. So we find these lymph nodes between the longus coli and capitis complex at the level of C1. We're going to think about that as longus capitis. But then we have the carotid and the jug out laterally. In between those is where we see retropharyngeal nodes. So this patient had a positive retropharyngeal node that was missed. Came back a year later, he had a positive retropharyngeal node that was missed. He came back a year after that. He still had a sore throat. It was getting worse. He had a positive retropharyngeal node that was missed. Now, we usually talk about nasopharyngeal carcinoma nodes going to those retropharyngeal nodes, nasopharyngeal carcinoma, but we can also get oropharyngeal and hypopharyngeal squames that may go to those retropharyngeal nodes. And the patient the next year came to my shop. We did an MR and got those old studies. And by that time, unfortunately, this had already invaded the skull base from this positive retropharyngeal node that was missed over and over again. This is obviously a very hard area to palpate. So if we don't look for those lymph nodes, we are not going to find them. Here's another case. This patient came in and they were being worked up years after a differentiated thyroid carcinoma was resected, and they had this unusual a retropharyngeal node in this location. And they thought that this might be separate from their prior thyroid carcinoma. So they worked up this patient, and we had a nice stir imaging where we saw the lymph node, and we did pre and post contrasted. They decided to pluck out this one node, and unfortunately, they cut into the node and spilled into the surgical bed. So we had seeding of the surgical bed, and just like a benign mixed tumor, that may be something that the patient may come back later with a lot of small cancers along the surgical bed. And unfortunately, it reminds us with a differentiated thyroid carcinoma that we may get very different imaging appearances on these patients. We might see fluid levels like we see on the stir. There's a straight line. There's not a lot of straight lines in the human body. We might see different signal. This is another node that was right next to it. They plucked out this node, but they left this node that was a medial retropharyngeal node right next to it. And there was actually a node on the other side that was missed because it was not as bright on the T2 and it was not enhancing as much as the other lymph nodes. So we probably did not change this patient's long-term M&M by doing this surgery. This is another unfortunate patient we had recently. This is a young woman who came in with headaches. They were kind of vague headaches, but on the workup, they found this lesion that was described as an enhancing lesion near the central skull base. And they worked up this patient at this location, and because it was bright on the T2, they decided that it might be a chondroid type tumor, like a chondrosarcoma or a choroidoma at that location. So this patient was referred to neurosurgery, and the neurosurgeons went in to resect this lesion because we called it a chondroid possible tumor, a tumor of the central skull base. Now, if you actually had looked at the pre-contrasted, you would see this actually is not an enhancing lesion. It was actually bright before we gave contrast. And they actually had another study that showed this lesion was actually much brighter before you gave contrast than it was after you give contrast. So this is actually not an enhancing lesion. This was a sinus disease that was extending up into this area called the Opticocarotid Recess. There's this very thin recess that may go up in between where the optic nerve is and the carotid and the cavernous sinus is sometimes called the Opticocarotid Recess. And this is actually just a mucus retention cyst extending up into that area. This was not an osseous lesion at that site. And it was bright on the T2 because it was just a fluid-filled cyst. So that was a case where we kind of misled our surgeons because we were leading them towards a chondroid matrix, and we did not pay attention to the difference between the pre-contrasted and the post-contrasted imaging. Now here's the CT, and you can see that anatomy where that opticocarotid recess is. This was just a cyst. If we had seen this in the maxillary sinus, it most likely would have just been called an incidental mucus retention cyst, but because it was seen here near the central skull base, and because we did not pay attention to the difference between the pre-contrasted and the post-contrasted, this case was totally missed at this location. So this is an area, especially in the head and neck world, we don't want to only look at the post-contrasted imaging. We really have to compare the pre-contrasted with the post-contrasted to be sure we evaluate these complex cases. Now, another thing that we want to pay attention to is the scout examination on our CT studies. And every now and then we have patients like this who just will not get off their cell phone when we tell them to stop talking when we're doing their scout. And sometimes the scout examination is relatively helpful, like we see this Leatherman tool that was embedded in this patient's forehead. But we have other cases where our tendency is to ignore the scout, and we want to be sure we pay attention to that. This is a patient who had a sinus CT, and we were looking at their sinuses, and it didn't look like there was a lot of sinus disease, but if we look closely at the scout examination, it looked like there was a lot of space here between the anterior arch of C1 and the dens. So we decided to work up this patient. We only saw this because we carefully looked at the scout on this study. So we did an MRI, we saw there was a lot of fluid there and some weird enhancement kind of around the dens. The patient actually wasn't that old. We decided to do flexion and extension, and we see that there's kind of correction here on extension, but there's a lot of widening between the dens and the anterior arch of C1 on flexion. And this patient ended up getting a posterior fusion. Obviously, they could have been in a lot of trouble with encroachment of the central canal, but that was something that was only picked up. It actually wasn't known about. We only saw this because we paid attention and looked at the scout examination. So we don't want to ignore the scouts on our CT And it's the same thing on MRI. We don't want to ignore those scanogram images. Sometimes that's the only place where we'll find the finding. So those are examples of what's called mistakes and slips. So mistakes, we can think about, you just didn't know any better. If you've never seen a pathology, it might be hard to pick up. And slips are examples of where we did know better, but we just made a mistake. And satisfaction of search, when we find one finding and stop looking for others, is an example of that, where slips can be misleading. So I'm going to spend the rest of the time talking about logic and rationality and how we use deductive, inductive, and abductive reasoning, and how sometimes these lines of reasoning kind of lead us astray. So we have these three different types of logic and rationality that we talk about: deductive, inductive, and abductive reasoning. Now, deductive reasoning, if a rule is told to you, and that's told that something that's always be true, then deductive reasoning is always going to be true unless that person is lying to you. So the idea here with deductive reasoning is determining the conclusion. So if I have a bag and I tell you that the bag is full of red marbles, there's nothing else in this bag, and I reach into the bag and I have a closed fist and I've taken out some marbles and I ask you what color the marbles are that I just took out of this bag, you would say red. That's an example of deductive reasoning. Unless I am lying to you, deductive reasoning is always true. But there are some areas where, because our imaging technology has evolved over time, there are sometimes things that we know are definitely for certain for rules that over time our patient population changes and our imaging evolves, and sometimes those rules are no longer as certain as we used to think about them. So next is inductive reasoning. If I have a bag and I take out a marble and it's red, and I take out another marble and it's red, and I take out a third marble and it's red, we could guess that this bag is full of red marbles. That's an example of inductive reasoning, or determining the rule from the conclusions. So that's how inductive reasoning works. And then lastly, we have abductive reasoning. If I were to walk in a room and there was a bag on the table that said red marbles, and there were a bunch of red marbles next to it, I would guess that these red marbles had come from this bag. That's an example of abductive reasoning, or determining the precondition. And this in our world is hoofbeats are usually horses. The most likely answer is usually the correct one. So that's an example of abductive reasoning. So we'll look at examples of each of these and how we use them and how sometimes they lead us astray in head and neck imaging. So first, deductive reasoning. Again, this is using the rules and preconditions to reach the generalization. So if I were to say to you, all humans are mortal, and I were to say, I am human, the next logical step is therefore I am mortal. That's an example of deductive reasoning in this world. So I'm reaching a conclusion by generalizing over a domain. Now, sometimes that leads us astray. I was taught when I started, 25 or 30 years ago, that anytime the nasopharyngeal tissues were really prominent in a patient who was over 50, they either had nasopharyngeal carcinoma or lymphoma. And I sent several patients to be scoped, and the pathologies all came back normal. And that's when we started looking more closely at our imaging findings. And I know now that if I see these linear septations, enhancing septations within Wildeyer's ring, I know that that's more likely to just be prominent adenoidal tissue that's reactive. So this is reactive adenoidal tissue when I see these inflammatory septations within it. And I see the same thing in the oropharyngeal palatine tonsils. So that's an example where deductive reasoning led me astray. Here's another example. Recently, it's a hot topic in the press of head and neck cancer. We talk about these HPV-associated oropharyngeal squamous cell carcinoma. If we have a patient who's over 50 and they have a cystic mass of the angle of the mandible, we want to think that that is most commonly a squame node. And my referring docs asked me to stick a needle in this, and I told them, well, I'm sure it's a squame node. Let's do a PET CT to look for the primary. But they said, well, we're just not really sure. And I said, well, I don't think this is an abscess. If the guy doesn't have a fever and a white count and he's not having pain there, it's very unlikely to be an abscess. But they kept pushing me to put a needle in it. So I finally stuck a needle in this case, and it was actually full of pus. And it was actually a diabetic abscess. We didn't know that this patient had very bad uncontrolled diabetes, and they basically had no immune system. So that's another example where deductive reasoning led me astray. Here's another case. I was always taught if we had bilateral enhancing lesions within the internal auditory canal, that was consistent with NF2 or neurofibromatosis type 2 or the MISME syndrome, MISME, multiple inherited schwannomas, meningiomas, and ependymomas. This patient has bilateral IAC enhancing lesions. Well, what we didn't know about the patient's history was that they had actually had choroid plexus papilloma that was resected, and they had diffuse metastatic disease. And this actually turned out to be choroid plexus metastatic foci within the bilateral internal auditory canals. So obviously that clinical history completely changed this patient and their workup. Here's another patient. I was always taught that if we had a really large mass that crossed the stylomandibular notch or stylomandibular tunnel, that case was going to be a benign mixed tumor. And this is a patient who had actually been worked up for several years, and this was called a benign mixed tumor over and over again in reports. Now, but when I looked at this case after the patient had been followed up for several years, I said, well, you know, these look like a lot of phloboids. That's very unusual for a benign mixed tumor. I do see how the parapharyngeal fat is displaced, and I see stylomandibular notch or stylomandibular tunnel, but this really does not look like a benign mixed tumor. We think about benign mixed tumors. Here's a nice example case that's in the exact same location, and again, crossing that stylomandibular notch or tunnel, the space between the styloid process and the mandible. The parapharyngeal fat is displaced similarly. Maybe it's pushed a little bit more anteriorly here in this case, but this is actually a lot of phloboids from a paraganglioma, not a benign mixed tumor. And we like those benign mixed tumors to be very bright on T2. Usually they're as bright as CSF. And in this case, this lesion was actually not that bright on T2. That's another thing that made me think that this was probably not a benign mixed tumor. So that's just another example of a patient who we had been led astray on by deductive reasoning rules, when in reality, this patient had had a glomus vagali paraganglioma that had been followed up for years and mistakenly called a benign mixed tumor over and over again. So that is deductive reasoning. Now the next level is inductive reasoning. This is using the conclusion to generate rules based on some kind of precondition. So if I were to say to you, all swans that I have ever seen are white, therefore all swans are white, that's an example of inductive reasoning that kind of leads you astray. Now, we know now that there are actually some black swans. They're very rare. So it's not actually true that all swans are white. But you can imagine a lot of cases where this has misled us in head and neck imaging. All the cases where somebody has told you, well, every time I've ever seen an example of this pathology, that has turned out to be this. So that's an example of inductive reasoning. And somehow, sometimes inductive reasoning also leads us astray in our workup of these cases. So here's a great example of this. So this patient came in and they had a neck mass. So I was looking at the pathology and I can see this is clearly between the carotid and the jug. And so here's the internal jugular vein flovoid and here's the carotid. So here's a well-circumscribed lesion. The surrounding soft tissues are not angry about this lesion. It's very well circumscribed. So I said that this lesion is most likely in the carotid sheath or space. And I know that we have nerve sheath tumors and nerve-associated tumors that happen in this location. I don't see any flovoids here to make me think this lesion is a paraganglioma. So I said this is most likely a nerve sheath tumor. And I even tried to apply intertumoral cysts to make this a schwannoma in this case. Now, this is a case that a couple of years ago, even though the enhancement was very strange for that case, this patient did not have any other history of anything else. So I thought for sure this was a schwannoma in this case. Now, this was a time where I had just started using ADC values 3 or 4 years ago in the head and neck, and I find them extremely helpful, actually. So here's the diffusion. It's a little bit bright, but here's the ADC. Now, I'm really using the ADC as a rough marker of tumor cellularity in these cases. I'm using the ADC independent of the diffusion. So I'm not really talking in these cases about restricted diffusion. I'm just talking about this lesion is dark on the ADC, therefore it's much likely to be hypercellular. And when I measure the ADC values of this lesion, it was actually very low. This number is times 10 to the negative 3 millimeters squared per second. But if we measure the region of interest on an ADC and that number is well over 1, because it's this number times 10 to the negative 3. So if it's over 1,000, it's much more likely to be hypocellular. And if it's less than 1,000, in this case it was 663, it's much more likely to be hypercellular and therefore more likely to be malignant. Now, there are some pertinent negatives in those cases, like lymphoma and meningioma, that are both hypercellular but not thought of as malignant in terms of more than 5 mitotic figures per high-powered field. So that's something we want to be aware of. In this particular case, though, I ignored these findings. I had this information right in front of me, but I was so sure on the other images that this was a incidental nerve sheath tumor that I ignored these findings. Now, we actually stuck a needle in this. We were discussing if this was a schwannoma or a neurofibroma, and very strangely, the pathology on this came back renal cell carcinoma. And it was certainly not something that I had had in my differential. And we went and worked up this patient. We looked at their kidneys, and sure enough, there was a big mass that was unknown on this patient's kidney. So this was an example of inductive reasoning that led me astray. I had that information with the ADC values right in front of me, but I ignored it because I thought for sure there was something wrong with the scan. It had been done incorrectly or something else. I was looking solely at the position on this case, and it was in between the carotid and the jug, so I was certain that this was a nerve sheath tumor, when in reality I had the ADC values right in front of me that was telling me something else, that I ignored it. So that was an example of inductive reasoning that led me astray. So next we have abductive reasoning. So we can think about this as using the conclusion and the rule to assume that the precondition explains the condition. So this is an example of hoofbeats are usually horses. So we think about abductive reasoning as inference to the best explanation. So this is actually, when we think about Sherlock Holmes, everybody always said excellent deductive reasoning. It actually was not deductive reasoning. It was actually abductive reasoning. What is most likely is probably what is going on in this case. Hoofbeats are usually horses, not unicorns in our world. Now, sometimes that's helpful, and sometimes it leads us astray. This was an unusual case, and this was the tomogram for the CT we were doing on this patient, and they had obvious, very prominent prevertebral soft tissue swelling. And we can see the endotracheal tube and the nasogastric tube being displaced way anteriorly. So we know the upper digestive tract is displaced very far anteriorly in this case. And we see all this prevertebral soft tissue swelling. So we did the CT here, and we saw all of this very bright density. So I was checking this CT, and I could not figure out what this high density was at this location. I could see the endotracheal tube and the nasogastric tube pushed anteriorly, but this is actually contrast from this patient's aorta that was rupturing and dissecting up through the cervical soft tissues. We see the carotid and the jug are both displaced way laterally in this patient by all this contrast in what's sometimes called the alar fascia, this slip of fascia between the prevertebral and retropharyngeal space. So this is an example of that danger space, a very rare case. We usually talk about retropharyngeal fluid and or retropharyngeal abscess that may extend inferiorly into this danger space, that this potential space is separated by this trap door where retropharyngeal abscess may extend into the mediastinum. But in this case, we actually had the opposite. This is contrast from the aorta that was dissecting up into the retropharyngeal soft tissues. So this is a very rare case of aortic rupture that was going on live on the scan. So here's another case. This patient was read out as a retropharyngeal abscess, and this imaging here was read out initially as a fluid collection with surrounding enhancement at this area. But this patient actually was a trauma patient. They didn't have fever, they didn't have a white count, and they didn't have anything else going on. When we think about a collection, though, at this area, especially if this is a fluid collection with surrounding enhancement, we think about that as an abscess anywhere in the body. But in this case, in reality, this was a pre-contrasted image. This is what the case looked like before contrast, and this is actually a spontaneous retropharyngeal hematoma. This patient was actually a trauma patient who was on blood thinners, and it turned out their INR was way off, so they were just leaking blood spontaneously and the retropharyngeal space. So this was actually an evolving hematoma. Here's another case. So here's a MRI, and we see this lesion here. This is post-contrasted. It looks like an enhancing lesion here within the nasal vault. So we're thinking about squamous cell carcinoma, maybe minor salivary gland carcinoma. We sometimes talk about lymphoma enhancing less than the nasal mucosa as an internal standard. Those are certainly some of the more common things we think about in the nasal vault. We might also think about some less common entities like a minor salivary gland carcinoma or a SNEC or SNUC. But if we look closely, this sagittal is actually before contrast. The nose is dark here, the nose. This is actually bright before we gave contrast. So this was not actually an enhancing lesion. This is actually a rare example of a T1 bright sinonasal melanoma. We actually had that information right in front of us. This is actually not enhancing. It looks the same before contrast as it does after. So we had all the information we needed right in front of it, but we ignored it. So that was an example of abductive reasoning kind of leading us astray in this case. Now, another example of a case, here's an axial post-contrasted CT, and we know that when we have a palatine tonsil primary, an oropharyngeal squame, we can have lymph nodes that often look a lot like the primary tumor. So we may have a solid tumor and solid pathologic lymph nodes with an oropharyngeal squamous cell carcinoma. But we know in patients that are moderately differentiated, we might have a more heterogeneous tumor and heterogeneous nodes, and especially in the case of somebody who maybe has been treated, or if they have a very poorly differentiated squamous cell carcinoma, we may have a very necrotic looking primary with very necrotic looking lymph nodes, especially if you have a lot of patient populations where you have HPV associated oropharyngeal squamous cell carcinomas. You might see a lot more of these very necrotic looking lymph nodes. Patients who have HPV positive oropharyngeal squamous cell carcinoma may have unimpressive primary tumors, but very impressive big necrotic lymph nodes in the same patient. So this is an example of lymph nodes from different primaries having very different appearances on their imaging studies. Now, this may be interesting in another case. This is a patient who actually had a skin squamous cell carcinoma, and they had some occipital lymph nodes back here at this location. But as we looked down lower in the neck, we saw some other pathologic lymph nodes that looked very different than these occipital lymph nodes, and it turned out the patient had a second primary. So when we just find lymph nodes, the patient presented with a neck mass, but we don't know about a primary tumor, we think about CUP, CUP, or carcinoma of unknown primary. But when we looked very closely at these lymph nodes that sometimes had very different appearances, it's hard to figure out sometimes, is this the carotid here? Is this the jug? This looks like a lymph node at that location. But some of these nodes actually looked very different that were right next to each other. And as we looked down lower in the neck, we saw this low basotongue primary tumor with some lymph nodes on that side and other pathologic nodes. But when we actually did surgery on this patient, we found out this was a squamous cell carcinoma node from this primary, but right next to it, there was actually a skin squamous cell carcinoma node. Very different differentiation, and they actually look different on imaging. So sometimes we have very different lymph nodes. So this reminds us of the importance of lymphatic drainage, and we'll talk about lymph nodes later in another lecture. But it's very important to think about with squamous cell carcinoma, what are the normal lymphatic drainage of lymph nodes? If we have a posterior head, a skin squame, and the patient shows up with level 2 nodes, but no nodes in between it, that may not quite make sense in the normal lymphatic drainage for that patient. So that's something we want to pay attention to in that case. Now, pulsatile tinnitus can be a very confusing thing. We may have patients who have twitching, for example, of the muscles in the inner ear, the little stapedius and the tensor tympani. But when patients have an actual vascular lesion, these are the most common entities that we find if a patient with pulsatile tinnitus actually has a vascular abnormality on their imaging. But it's something that may be very difficult to evaluate on our patients. This is a very rare patient, a nice example of a case where a patient had been worked up, and we see the bone here behind the mastoid air cells looks relatively solid. And years later, they presented with pulsatile tinnitus, and at that time, they showed up with all these lines. They were a bunch of blood vessels going through the bone at that level. So we actually have evolution here of a dural arterial venous fistula in this patient. So we worked that patient up, and on MRI, we saw all those little blood vessels around this thrombosed dural sinus and all those collaterals connecting the internal and external collection at that level. And here in this patient, we see the normal sinus on one side, and we have a thrombosed sinus on the other side that led to the thrombosis in that case. Here's another patient. This was a 42-year-old patient who showed up with neck pain. They had initially denied having any history of IV drug use, but when we came in and worked them up, they were having neck pain, and we did an MRI and saw this very strange appearance, obviously very odd for a 42-year-old to have IV drug use, and that a 42-year-old to have a big degenerative pannus around the dens. We would be thinking about something else in this case. So we worked up the patient. We saw this abnormal soft tissue. On the post-contrasted, it looked like a lot of it was enhancing. So we were very confused about this prevertebral soft tissue in this patient who denied any history of drug use, and we actually saw some abnormal cord signal in this case. And on the CT examination, we saw some increasing laxity. Here, the anterior arch of C1 in the dens. This space was increasing over time. And when we looked out laterally, we saw the relationship between the occipital condyle, the lateral mass of C1 and C2, how that facet of C2 was actually digging over time, over just a few weeks, into C1 in that case. And this patient, we finally got one of their visitors, one of their friends, to tell us that this patient actually did have a long history of IV drug use. And we worked up the patient and found out that they did, in fact, have a positive blood culture, and they had a blood infection that was led to this abnormality. So unfortunately, we know that the clinical history can sometimes be misleading for us, but we want to pay attention to it. So that's an example of what we consider kind of mistake slips, deductive, inductive, and abductive reasoning. So we want to pay attention to all of these when we think about evaluating our cases and ways that we can make mistakes. So we have mistakes. Sometimes we're just not familiar with some pathology or how pathology looks on imaging. You just didn't know better. That's something that happens to all of us. We're all learning. If we're smart, we're going to recognize that we're always learning, and we can always look up things. Then we have slips. Sometimes we knew better, but we just made a mistake, like saying right instead of left. So one example of a slip that we want to remember is the satisfaction of search. Don't stop looking just because you found an abnormality. Be sure to keep looking and see if there's anything else abnormal on that study. Then we have deductive reasoning. Again, with deductive reasoning, there's a rule, and if that rule is true, then it will always be correct and never lead you astray. But we want to pay attention that sometimes our patient population changes, like we have patients who may not have an immune reaction who are horrible diabetics. So that may be where deductive reasoning leads us astray. Then we have inductive reasoning, that things are usually true. If every swan I've ever seen is white, I can say that all swans are white. Well, you can imagine a lot of examples how that has led us astray in our imaging, just like that case that I thought was a nerve sheath tumor. And then we have abductive reasoning. This is probably the one that's most important. If hoofbeats are usually horses, we want to think about the common entities as being the most common. And it's far more likely to have an atypical presentation of a common entity than it is to have a common presentation of an atypical entity. So abductive reasoning is the idea that hoofbeats are usually horses. So we can think about, very simplistically, kind of fast thinking as biases, but the deductive, inductive, and abductive reasoning are areas where we try to apply logic and rationality, but sometimes that leads us astray. And this is slow thinking, which is, I think, is very interesting in how we try to use logic and rationality to evaluate our cases, and sometimes that can lead us astray. So that's a review of what I think about as Fallor Ergo sum. I fail, therefore I am. I think it's important that we pay attention to our misses, because we can learn a lot from that if we think about how logic and rationality sometimes lead us astray. And I thank you very much for your attention. Okay, so
Thank
I'll
you.
go over to our chat room, see if we have any questions.
Thank you, Rick, for this amazing lecture. I think for most who've been around the block, we've all been there, we've all made mistakes, and we've all learned of this. I think the take-home message of this is that we cannot practice head and neck or in isolation. You need to be in a multidisciplinary clinic to make consensus, concordant or discordant decisions. But the amazing...
Yeah, it's an example where I've seen a lot of people try to explain away their mistakes. And I think we're doing a disservice to ourselves when we think about that. We have to become intimate with our own fallibility. We have to recognize that we all make mistakes. The only people who are not making mistakes are the ones who are not reading studies. But our mistakes are great opportunities for us to learn and to teach others. So I try to pay a lot more attention to those mistakes over time.
But I mean, that's essential because as you've alluded to in your introduction, is that we publish our successes and our failures as basically wiped under the carpet. So thank you very much for this. Our email inbox for questions or comments are open. We've got a few minutes. Eric, are you online? Rick, can you see your inbox?
Yep, I don't see any questions or in my inbox. Now you know everything I know about head and neck imaging.
Well, the point is it's I think it's one of the disciplines in
Here's
medicine.
a question from David. What is the difference between vestibular schwannoma and facial nerve schwannoma? So in the internal auditory canal, we have 4 little nerves that are going through there. And if the tumor is actually extending along the facial nerve, that's very important for us to try to differentiate from a tumor that may be going along the vestibular nerve. We don't want to cut out a vestibular schwannoma and find out that the patient couldn't move their face postoperatively in that case. That's obviously a big mistake for us on our imaging. So if I go back to that slide that I have, I can show you. This is a facial nerve schwannoma. Anytime we have an enhancing lesion within the internal auditory canal, you want to look very closely along the labyrinthine segment right here that we talked about before with the temporal bone anatomy, because the patient may actually have a facial nerve schwannoma instead of a vestibular schwannoma. In this case, there was enhancement along the labyrinthine segment, and there was too much enhancement at the geniculate ganglion. If this was a vestibular schwannoma, this enhancing lesion should extend towards the cochlea and the vestibule. It should not extend towards the geniculate ganglion. So that's very important for us to differentiate a facial nerve schwannoma from a vestibular schwannoma. So anytime we talk about a vestibular schwannoma, you want to look at the lateral aspect of the internal auditory canal and be sure there's not enlargement or enhancement extending along the labyrinthine segment of the facial nerve, because that may tell you that that is actually a facial nerve schwannoma, not a vestibular cochlear schwannoma. So that's a great question. A very important differentiation for a rare lesion.
Yeah. So basically the differentiating feature is the geniculate ganglion. We must pay attention to that. If you see an enhancing lesion in the internal auditory canal, you need to follow it out and pay particular attention to the morphology and enhancement of the geniculate ganglion to differentiate, not to miss a facial schwannoma.
Yep.
Any more questions in the inbox, Eric?
No, that's all.
Anyway, Rick, thank you very much for another superb presentation. We really appreciate it. And we'll talk in a few weeks' time. Thank you very much. Have a good night.
You too. Thank you. Good night, everyone.